generally good. The typical course is kidney recovery. Tubular cells are capable of regeneration. The kidneys and the nephrons can undergo a process called tubular re-epithelialization. This is why the kidney function usually recovers. There are some patients who require temporary dialysis, especially during that maintenance phase, to keep their levels of potassium normal. Interstitial nephritis, which is also sometimes called tubulointerstitial nephritis. And the interstitium. The interstitium is the space between cells in the kidneys. This is a hypersensitivity or nephritis, and the inflammation involves the renal tubules and the interstitium. The interstitium is the space between cells in the kidneys. This is a hypersensitivity or allergic reaction that is mediated by eosinophils and neutrophils. It's usually a response to a drug, and we'll talk about some of the typical drugs, although sometimes it's a response to an infection or an autoimmune disease. And it usually resolves if you stop the offending agent, especially if it's caused by a drug. The main clinical feature is intrinsic renal failure. There's a rise in the BUN and creatinine and a fall in urine output. Importantly, there's absence of the nephritic or nephrotic syndrome. When any of these things are present, then it's considered a glomerular disease. What makes something interstitial nephritis and not a glomerular disease is the fact that there's no evidence of nephritic or
ल ल भयो भयो ल पढ्न जा म पढिरहेको छु डु नट डिस्टर्ब मी खोइ रिप्लाई आउँदैन त अरे अहिले ब्रेकमा अहिले 1 घण्टा पढेपछि 1 hour study 10 minutes break
related renal failure. Drugs are the most common cause of interstitial nephritis. They cause about 75% of cases. Some of the drugs that classically do this are listed on the slide. Sulfonamides can do this. Rifampin and penicillins may cause interstitial nephritis. Some diuretics may cause interstitial nephritis, like furosemide, bumetanide, thiazides. And then finally, non-steroidal anti-inflammatory drugs can cause acute interstitial nephritis. The mechanism by which these drugs cause nephritis is often by acting as a hapten. I talk about haptens in the immunology section. They are molecules that elicit an immune response when they are bound to tissues or cells. And in many cases, these drugs attach to the basement membranes or to tubular epithelial cells, and they trigger an immune response. Other causes are associated with infection. There are many organisms that have been reported. Interstitial nephritis has been associated with sarcoidosis, Sjogren's syndrome. Sometime in the last few days or evidence of inflammation and an allergic reaction. So they might have a fever, they could have a rash, and they will have malaise. On serum blood testing, you will see evidence of acute renal failure with a rise in the BUN and creatinine. When you examine the urine, you may see white blood cell. You will see them without evidence of cystitis. And this is a very important point. Shown on the screen is a white blood cell cast, and I talk about these in the urinary tract infection video because they're the hallmark of a UTI. But you can also see white blood cell casts in interstitial nephritis. nephritis because there are white cells involved in this process as well. Importantly, a patient with interstitial nephritis will not have burning or dysuria or any evidence of cystitis. Those things are only seen with infection. So if you see a case describing white blood cell cast with no evidence of dysuria or cystitis, you should think of interstitial nephritis. This is called sterile pyuria because there are white cells in the urine, but there's no bacteria. Also, because it's an allergic reaction, there may be peripheral eosinophilia, and sometimes you can also see eosinophils in the urine. As I told you before, this is usually a benign disorder. The symptoms resolve with stopping the offending agent, but in rare circumstances, it can progress to something called papillary necrosis, and we're going to talk about that a little bit later on in this video. There is a chronic form of interstitial nephritis. This involves mononuclear cells, and it leads to fibrosis and atrophy of the tubules. This is seen only among patients with long-standing use of high levels of non-steroidal anti-inflammatory drugs. So in a board question, this is always going to be someone who's got some type of joint pain or other condition and takes lots of NSAIDs every day. There will be a mild elevation of the BUN and creatinine. It will resolve with stopping the drug. So the classic case is a patient on chronic NSAIDs for chronic pain with a mildly elevated BUN and creatinine, and the renal function improves with stoppage of the drug. That patient likely has chronic interstitial nephritis. Let's pause and talk about NSAIDs for a minute because these drugs are associated with a number of different kidney problems. As I mentioned earlier, NSAIDs can cause acute interstitial nephritis. This is an acute allergic reaction to the drug, so it will present with fever, potentially a rash, and evidence of renal failure. NSAIDs can also cause chronic interstitial nephritis, so these patients will not have fever or rash or anything like that. They will simply have renal failure. They're usually asymptomatic, and this is usually picked up on incidental blood work, and what's going on is a chronic inflammation in the kidneys related to NSAIDs. NSAIDs can also potentially cause acute tubular necrosis. This is because they can lead to ischemia. NSAIDs block prostaglandin-induced vasodilation of the afferent arterioles with papillary necrosis, so let's talk about that now. Papillary necrosis refers to coagulative necrosis of the renal papillae. The renal papillae are this portion of the kidney that I'm marking with my pen. This is where the pyramids empty urine into the collecting system for passage on to the ureter. When this happens, this leads to sloughing of tissue and gross hematuria that is often painless. And the word gross is very important here. So often when we talk about hematuria in kidney diseases, we're talking about microscopic hematuria that you only see with the microscope. The situation is different in papillary necrosis because you have sloughing off of large pieces of tissue. Patients will report that they see clumps of blood in their urine. That's very unusual. That's gross hematuria, and that's what you see in papillary necrosis. Also important to understand is that when this occurs in isolation, there's no intrinsic renal failure or white blood cell cast. That's because the glomeruli and the tubulars are not found in the papillae. So when you have damage to this area in isolation, the kidney function remains intact. Now, you can get renal failure and papillary necrosis. That's because the tissue that sloughs off may obstruct urine flow, but you shouldn't see intrinsic renal failure like you do in glomerular diseases or tubular necrosis because those portions of the nephron remain intact. Some of the classic causes are shown on the slide here. Phenacetin is a drug no longer on the market. It used to be used for pain control, but it led to some tumors and kidney failure. Tylenol is a phenacetin derivative, which is still used today. Diabetes can also cause this. This can be a consequence of acute pyelonephritis. And then finally, the most important cause to remember in terms of your boards is sickle cell anemia. This of the renal cortex, your renal failure. These especially placental abruption or